Discuss acromegaly here. Acromegaly generally occurs due to excess of growth hormone. So the basics you need to know about growth hormone now are that growth hormone is also known as somatotrophic hormone, and it has an antagonist hormone which is called somatostatin. This somatostatin has the exact opposite effect compared to somatotropin or the growth hormone. Now, another thing you need to know is growth hormone generally acts by two mechanisms. One mechanism, it directly attaches to its receptor and works, and in the second mechanism, it acts by acting on the liver that releases insulin like growth factor 1 that further causes the action of the growth hormone. So if I estimate the amount of insulin like growth factor 1, it can be it can be used as a screening test in order to find the indirect levels of growth hormone. So in acromegaly, there is increased growth hormone. So the causes can be two, that the causes that are primarily associated with the hypothalamus and pituitary. So the pituitary releases the growth hormone, and in pituitary there can be a adenoma, that is the most common cause, and it can also be ectopic secretion of growth hormone secondary to pancreatic islet cell tumors. Now, in hypothalamus, it can release growth hormone releasing enzyme that can act on the pituitary to release growth hormone. So here in hypothalamus as well can be a tumor in the form of a hamartoma of the hypothalamus, HT, and it can also be an ectopic secretion of GHRH that can be secondary to lung cancer, then give secondary to medullary carcinoma of the thyroid, and it can be secondary to the bronchial carcinoid. Now, what are the effects of increase, or what are the changes that we see in acromegaly? In acromegaly, basically the primary change that we see is the acral enlargement. Now, this enlargement generally occurs in the peripheries, because in acromegaly generally happens in adults. So by the time the growth hormones effects takes place, the epiphysis has already fused. So, and there is enlargement of the hands and feet in the peripheries, and all organs are enlarged, mostly liver, spleen, heart, etc., except the brain. Now, moving forward, we have also what we call as coarse fascies. In coarse fascies, the feature that we can see here are, there is frontal bossing from top to down. I am speaking. There is frontal bossing. Then there is prominent supraorbital ridge. Then we have thick lip and nose. Then we have jaw malocclusion. Then we have prognathism, that is the maxillary or the mandible is larger and the mandible is small and fits under overlapping the maxilla. And then we have macroglossia as well, and jaw malocclusion. As far as organ involvement is concerned, in the neuromuscular system we can see myopathy. In nervous system we can see carpal tunnel syndrome, and then in CVS we can see there is increased risk of coronary artery disease and heart failures. In ophthalmology we can see there is increased chances of glaucoma, angle closure glaucoma. In the respiratory system there is increased chances of obstructive sleep apnea. In GIT there is increased chances of polyp formation. In skin, seborrhea and hyperhidrosis, like sweaty hands and sweaty palms. And of course in gonads we have what is called oligomenorrhea. Now, what are the metabolic manifestations? The metabolic manifestation, first, as far as glucose is concerned, it can lead to hyperglycemia and diabetes. It can cause lipolysis, cause increased triglycerides. Then it can cause hypercalcemia and hyperphosphatemia, and it can also can also cause salt and water retention and thyroid enlargement, leading to goiter. Now, how can we diagnose this? So already I've told that it acts indirectly by insulin like growth factor 1. So basically I can assess the insulin like growth factor 1 levels in order to see that whether GH is raised or not. So if the IGF-1 is raised, then I go for a confirmatory test in which I measure the serum growth hormone. If the serum growth hormone is more than 1 nanogram per ml, then I go for imaging to see if there is any adenoma or if there is any ectopic mass producing growth hormone. So generally the investigation of choice here is an MRI. At the same time, I'll also do one thing. I'll check the other hormone levels. Generally, if it is a lesion that is associated with the pituitary, all the hormones might be raised that are released, like growth hormone, then TSH, then ACTH, then LH, everything might be raised. And if it is a hypothalamic cause, then if it's a lesion causing then the all the releasing hormones will be produced in less amount, and the pituitary hormones from the anterior pituitary will also be produced in less amount, except for prolactin, because the hypothalamus only produces the prolactin inhibitory hormone. It does not produce something called prolactin releasing hormone. So if the inhibitory hormone is produced less, the amount of prolactin increases. Here what will happen, it's a separate thing, that all the releasing hormones, so basically in this case what is going to happen is all the releasing type of hormones will increase. So here all the pituitary hormones might also be increased. Now in treatment, basically first we have a medical treatment. In medical treatment, what we do is we give first of all somatostatin analogs like octreotide and pasireotide. There are dopamine receptors present on the pituitary that decrease the secretion of the pituitary hormones, so we can give dopamine receptor antagonists like bromocriptine and cabergoline. And then there is also a growth hormone receptor antagonist called our pegvisomant. Here you can see that it's somant means somatotrophin antagonist. And if there is a mass, we have to do surgery. The surgery of choice for microadenoma and macroadenoma is transsphenoidal hypophysectomy, and that would finish acromegaly.